Yes, definitely we can start. As we have shown in previous slides also, the de novo hospitalized patients, that is patients who are not previously known heart failures, who are not exposed to ARBs or ACE inhibitors previously, or even any other medications, they do very well with ARNI. So this is one of the studies that 66% of the patients are actually newly diagnosed in the PREVENT study, and 43% of the proportion of overall patients were de novo heart failure patients. So these data have come from these studies. So it has shown significantly lower incidence of composite cardiovascular death and heart failure rehospitalization in de novo hospitalized patients with sacubitril valsartan. So this is the transition study we have talked about already, and it shows that the newly diagnosed, that is de novo or chronic heart failure patients, they benefit from very early initiation of ARNI even in newly diagnosed heart failure patients. So sacubitril valsartan, we can see it improves cardiac remodeling and pump function more efficiently compared to ACE-ARBs in de novo hospitalized patients with heart failure with reduced ejection fraction. These are all the parameters. It decreases the troponin T concentrations also, and the primary endpoints we can clearly see that it benefit even in de novo heart failure patients or patients with heart failure with reduced EF. Also, the benefits, the p-value are significant even in de novo heart failure patients. So these are the results, that early intervention with sacubitril valsartan should be considered to delay disease progressions in patients with de novo heart failure. So these are 2021 updates to the 2017 ACC expert consensus decision pathway for optimization of heart failure treatment. So it clearly shows that in stage C means the treatment, the patients who require heart failure treatment, and it shows that ACE and ARNI is preferred over ACE and ARBs as the foundational therapy along with beta blockers and diuretics. There is definite new evidence that ARNI is now also recommended in newly diagnosed patients, that is ACE or ARB naive patients, because paradigm HF, we had the information that those patients who were already on ACE and ARBs, those were the patients who were considered. But now with the new trials, it is pretty much clear that in de novo heart failure patients also who are not been exposed to ACE or ARBs, ARNI is equally beneficial and even more beneficial as compared to ACE inhibitors. And our aim should be to achieve the optimal guideline directed medical treatment within 3 to 6 months of the initial diagnosis of our heart failure. So ARNI can be considered as a first line therapy instead of ACE inhibitors with heart failure with reduced EF. This is the European guideline recommendation. This is the slide we have discussed, that ARNI is the #1 class 1 indications. Only in patients where ARNI use is not feasible, you can go for ACE inhibitors, and those patients who are not intolerant to ACE inhibitors also, you can consider angiotensin receptor.